Well, welcome. Thursday afternoon. Today we're delighted to have with us Dr. Terry Weiner. He's going to talk about the comparative health systems. Is the U.S. the best? First of all, before I introduce Dr. Weiner, let me say thank you to the CCT for hosting this fascinating webinar. And thanks also to Dr. Terry Weiner for coming to present his thoughts and research on the subject, which is considerable. And finally, thanks to Sephora Brown for all of her work in setting up this webinar and for her role in making it a going project as we work our way through it. A lot of technical stuff behind the webinar such as this. And thanks to any other staff and folks at CCT who have made this possible. Just a little housekeeping here at the beginning. This is a webinar and you will not be seen and you do not have access to the video part of a webinar as you would at a Zoom meeting, nor do you have access to speaking up. And so everybody is mute by nature of the webinar itself. And so how do you get your questions out there? Well, just go to the Q&A and pose your questions there. You could raise your hands, but we really can't recognize anybody at this point. We're going to wait till the presentation by Dr. Weiner is over, and then you can pose your questions in the Q&A section. And at the end of Dr. Weiner's presentation, I will then present those questions to Dr. Weiner. Dr. Terry Weiner served for 5 years at Russell Sage College as provost. Before going to Sage, Dr. Weiner had been at Union College in Schenectady, New York, for 35 years. At Union, he served in the administration as Associate Dean of Faculty for 8 years and as a special assistant to the interim president for 1 year. He's had a successful career at Union, including serving as the chair of the Department of Political Science for 7 years, and earlier as chair of the Department of Sociology and Anthropology. He received his PhD from the University of North Carolina at Chapel Hill in sociology, and his undergraduate work was done at the University of Illinois at Chicago. Dr. Weiner's had a long career in which he's published and given talks at professional meetings and universities in the areas of his research, including healthcare policy, educational policy, and political behavior. He was named the Chauncey H. Winters Professor of Comparative Social Analysis by the Union president in 2003. And so it's with great pleasure that I introduce to you Dr. Terry Weiner.
Thanks, Richard, and good afternoon to everyone. I'm going to try to, actually I got to try to advance there we go. I want to talk a little bit about, because on the advertising for this talk, how healthcare systems have responded to COVID. I know that's on everybody's mind. We're all participating in the Hunger Games down here in Florida, trying to get our shots, the first and the second shot. So let me talk a little bit about how COVID has gone internationally. If we look at the United States and compare the United States to the countries in Europe or Asia, for example, we are not doing very well, but we're actually not the worst. If you look at, for example, the cases per million, the United Kingdom and Italy are pretty much ahead of us by about 10% to 20%. More cases per million in their countries than in the United States. On the other hand, France, Canada, Germany have significantly less our rate of COVID than we do here. The United Kingdom, though they have more cases, are doing twice as much testing as the United States. So there are about 10% more cases there, but they are doing 50% more testing. On the other hand, Germany and Canada have invested less in the testing than the United States. What does all this mean? particularly relative to the question that's before us today on whether or not the United States has the best healthcare system or not. I would argue that COVID is a poor test for determining whether or not a healthcare system is good or bad. It really is a better test for asking the question whether or not countries have significantly invested in public health and public health infrastructure. But the real, I think, variable that makes the most difference in explaining the response to COVID or the success countries are having or not having is really political leadership. Political leadership made a difference here in the United States in a negative way. We had very little political leadership. We had a great deal of denial going on. We had very little willingness to model good behavior by our political leaders and the dominant political party at the time. And we were unwilling to unite around a plan involving the use of NPIs, which means non-pharmaceutical interventions like masks, social distancing, and things like that. So for the most part, the differences in outcomes for COVID has really been a test of political systems more than it has been a test of health systems. So I'll leave it at that and turn to our fundamental question of the day, which is whether or not the United States has a healthcare system compared to other countries that would be something that others would want to model or not. First, to answer that question, we have to really go to the basics, which is to ask the question, is healthcare really a right? And other countries, other than the United States, have answered this question fundamentally different than the United States. In Europe and even in Asia, most countries have argued that healthcare is a basic fundamental human right. The United States has defined rights much differently than you find in Europe and increasingly even in Asia. And let me just do a little political sciencey thing here to talk about the distinction between negative rights and positive rights. In the United States, we have focused on thinking about rights as something that we have a right to be protected from something. And usually the from means the government. We want to protect ourselves from the government interfering with individual rights. But in Europe and in Japan and in South Korea and in other countries like that, they think of rights as both negative, protection from, but also obligations of the government to its individual citizens. Positive rights, meaning that individuals have a right to claim that the government has a responsibility to take care of its citizens, ensure its general welfare, and to make sure that they are healthy and have access to health care. In the United States, we do have state constitutions which do talk about sometimes health care as a right, but for the most part, when we think about health care as a right in the United States, we generally are only talking about emergency care. All individuals in the United States, by law, do have access to emergency care. No one is going to be turned away at an emergency room, but that is it. There is no right to other kinds of healthcare resources necessarily. So there's a fundamental difference in how Europe and the United States thinks about healthcare at a fundamental level. Well, should healthcare be a right? Should the United States think about this differently? And here I will, talk a little bit about the ideas of a philosopher named John Rawls, who arguably is maybe the 20th century's most important and famous philosopher. And in his theory of justice, John Rawls talks about the fact that most humans are unable to look at problems without bias, that we are all biased by our social position. No matter who we are or where we are, we all have a certain amount of bias. So then how do we determine what is just, if you will? And that's what Rawls tried to ask the question. And he argued that to do that, we had to get ourselves behind a veil of ignorance. In other words, essentially, to see how we would feel, would we perceive the world as just if we had to live in a society where we would have a fairly high risk of being uninsured, having no access to health care, or even being on Medicaid, as opposed to having the health insurance that we currently have. And most Americans, I think, would say they would be uncomfortable if they had to trade the health care that they are getting, particularly affluent Americans, for that they would get under Medicaid or if they were uninsured at all. So when you think about whether healthcare should be a right, think about how you would feel about the healthcare system if you weren't in your current position, but in another position altogether. Well, if we're going to ask the question whether or not our healthcare system is better or worse, we have to have some benchmarks. How are we going to compare one system versus another? How are we going to decide what the criteria are, what are the variables we should look at to determine whether one system is better than another? Well, political scientists and sociologists and healthcare experts who have studied this have come up with a list, and it's not necessarily the most comprehensive list, but I'm going to give you some of the variables that have typically emerged as what we call benchmarks of fairness, how we can compare systems. And the first thing I would mention as a benchmark is universal access. If a healthcare system is going to be considered to be good, of high quality, we would assume that it would have universal access, that everyone in that society would have access to the healthcare system, regardless of their healthcare risk, and how well they are or how sick they may be. The second benchmark of fairness would be, do you have access that is not having a financial barrier? In other words, it's okay, in many European countries, in fact, do charge for access to healthcare. In Sweden and many of the Scandinavian countries, there is in fact a small charge, if you will, a copay. But that amount is usually very small, so as not to present a financial barrier to access. Okay, so that there needs to be no real significant financial barrier to accessing the healthcare system. My coverage should be fairly comprehensive. That is to say, if we're going to offer health insurance, whether through the state or through private nonprofit mechanisms or through for-profit mechanisms, the benefits that are provided to the citizens should be fairly comprehensive, meaning they should cover physician care, hospital care, reasonable amount of rehabilitation care, and things like that. Access to drugs in the hospital should be covered. Access to drugs outside the hospital should be done so with a minimal amount of financial barriers. Another characteristic of the healthcare system that we are going to be concerned about is whether or not people can afford, if you will, to purchase insurance if that is required. If it's not going to be provided by the state, is the ability to afford that insurance going to be affordable to the majority of citizens? Obviously, if we're going to provide health care, it's no good to provide health care that isn't of high quality. It's one thing to say that everybody should have access to health care, but if it's of very poor quality, you haven't really accomplished very much, have you? So obviously, a very important benchmark in comparing healthcare systems is the quality of care that is provided. Is it evidence-based? Are doctors and hospitals relying on evidence, or are they relying on anecdote or just simply patterns of practice that have become traditional? Healthcare systems should be financially efficient, meaning that they should have little waste. No one wants to set up a healthcare system that simply wastes money. Tax dollars, if they're going to support healthcare insurance, in other words, if you're going to have a state-sponsored health insurance system, Well, you don't want that money being wasted because tax dollars are precious and they can be used to support schools, they can be support highways, they can be used to support Social Security, they can be used for a variety of things, not only healthcare. So when you spend money on healthcare, you want it to be efficient. You want it to be accountable and transparent. That is to say, whatever the healthcare system is doing, it should be accountable. That is to say that the healthcare outcomes, the behavior of doctors and of hospitals should be transparent and be open for inspection to others. And then finally, it's reasonable to say that if we're going to have a healthcare system, we want people to have choice. No one in any society wants to be told they must go to a particular doctor, or they must go to a particular hospital, or they must get their imaging done at a particular venue. Most people in all societies, uh, uh, certainly most advanced societies, are going to insist on a reasonable degree of choice in their healthcare system. So that's a reasonable benchmark for comparing healthcare systems. Okay. Before I go too much further, I want to state the obvious. We don't have national health insurance in the United States. And so the fundamental question we're going to be asking today is, well, not only why not, but should we? Should we have uh, a different kind of way of organizing our healthcare system? Would we be better off? And one way of testing that question is to look at other countries that do have it and see how well they do. Well, in the United States, we clearly don't have any national health insurance, and it has mostly to do with our political culture. A fear of socialism, as you know, as we've seen in the last election cycle. If you label something socialist, some people run for the hills, even though they're not exactly sure what socialism is. There are no pure capitalist societies left in the world. All countries have a degree, if you will, of government intervention in the economy and government provision of services. So all societies are really, modern societies are really on a continuum of, if you will, from capitalism to socialism, with most being somewhere in the middle. So nonetheless, in the United States, if you say something is socialist, it is often misunderstood, and consequently the people don't support it. There's generally, since 1776, comes with the history of our society, built into American political culture for 250 years, has been a mistrust of government. We are a society that has always mistrusted government. The American Revolution was a revolution from tyranny and aristocracy and all the rest. And we do not want to replace the tyranny that we uh, threw over in 1776 for another set of tyranny. So there has always been a mistrust of government. And I think really since the beginning of the 20th century, a perception of government incompetence, that as government grew and began to perform more functions, increasingly people began to perceive that when government did things, it did things less competently than in the private marketplace. Any economist, well, not any economist, but most economists will tell you that the data on this is actually not true, that most government institutions actually are quite competent and perform their functions very well. Indeed, if you were to compare Medicare, for example, to private insurance, the overhead on Medicare is significantly less than it is for most private insurance. So the fact is the government is not incompetent, but Americans tend to think it is. Another problem with moving forward to have a European model is that, in fact, 2/3 of Americans, really more than that, have insurance. They already have insurance. And when you're thinking about changing systems, as Bernie Sanders was talking about during the primaries, if you may recall, last year, trying to replace it with a single payer Canadian model or some other form, you're going to have people who are voters not too happy, because they are going to worry. You're going to raise people's anxiety about the fact that you're taking away their current insurance and replacing it with something they're not sure about. And that is going to create political problems. And then Americans, probably like most people the rest of the world, but more than other countries, certainly more than in Europe, we have a fear of taxes. Americans do not like to pay taxes. I'm not saying that anybody else likes to pay them. I'm not sure that the French are thrilled about paying taxes either. Everybody would like to keep them more modest. But in our political culture, the opposition to taxes is greater than it is in Europe. In Europe, there's a sort of cultural appreciation that you're going to take our taxes and you're going to give us services. You're going to give us schools. You're going to give us health care. You're going to give us protection. You're going to give us police. You're going to give us fire protection, et cetera. People seem to understand the quid pro quo that comes between an individual and its government much more than they do in the United States. So these are factors that help explain why we don't have health insurance, like a single payer system in Canada. But we also have other political problems. I'm just going to quickly mention them. Congress, getting things through Congress is difficult, unlike other parliamentary systems where you only have to get things through the House of Commons, for example. There are many veto points in the American political system. As you all know, if you remember Political Science 101 from college, you know that if Congress passes a law, it can be vetoed by the president. Congress can override the veto, but then the Supreme Court can declare it unconstitutional. But if they do that, Congress then can pass an amendment to the Constitution. All that suggests that change in America is much more difficult politically than it is in many other political systems. Another fact is that we started down in the 1930s down if you will, a road for providing health insurance that really crystallized during the 1940s during the war and World War II. And that system is the employer-based system. Because wages and benefits were frozen during World War II, the United States decided that we would allow employers to compete for a very scarce skilled labor force by offering fringe benefits, including health care, to encourage workers to stay with their firm as opposed to going to some other firm. And that sort of set us down the road, what we call the employer-based model, or the employer-based system of offering health insurance. And what we learn in political science is that once you start down a road, if you will, you get a kind of what we call path dependence, which is that we are now stuck with an employer-based system because we've had it now for 80 years. And it's very difficult to move away from a system that has really sort of ingrained itself in the way we organize our healthcare system. Democrats have always been divided over proposals. If you remember the campaign for the presidency, Joe Biden did not support a single payer Canadian model. He wants to improve the Obamacare, while Bernie Sanders, of course, wanted a Canadian model. So one of the problems that impacts change is that the change party, if you will, the political party that wants to change the healthcare system, can't agree on how to change it, which makes change difficult. Obviously, the role of money and lobbying influences our politics, and the opposition by the American Medical Association and insurance companies to change has also been an obstacle. So let's talk a little bit about the American healthcare system, and now start getting into a little bit of data on how we might compare it to other countries. One of the myths about America, and I hope people don't get too upset because, well, let me just say that many Americans believe that all in the United States are cared for if they really do need it. That isn't true. That just simply isn't true. We know, for example, and I know this is going to be a stunning statistic, that at least 26,000 Americans each year die, and you could argue that they die because they didn't have healthcare insurance, that was the primary reason that they died. Obviously, there's no disease called no insurance. Obviously, people die of diseases, But when healthcare experts look at this, they say, well, if this person had had insurance, would they have been cared for and lived? And the answer is probably at least 20 to 30,000 Americans each year die because they simply didn't have insurance. That we have the best care. Well, you're going to see in a minute, we do not have the best care. Another myth about the United States is we don't ration and Europe does. Well, that myth comes from the fact that people don't understand the term ration. In the United States, we ration all right. We ration by price. And in Europe and in Asia, they ration by supply, meaning that in the United States, some people get really good health care. In fact, most of us attending this webinar wouldn't trade our health insurance or probably even our health care for anything in the world. And rightly so, because at its very best, the United States is outstanding. Our best hospitals, we have outstanding medical schools and outstanding practitioners of medicine here in the United States that do outstanding research and deliver high quality care. But somebody has to pay for it. And the people who can pay for it get that care. But there are those that cannot. And therefore, they are rationed. They get less care. There's no argument, really, we have a two-tier system. For those that can afford it or those that are insured, our system is spectacular. In Europe, they argue that the way to deal with the problem of rationing is by rationing supply, meaning is access to care is universal, but the supply of high technology care is rationed so that the cost is kept down. We'll talk a little bit more about that in a few minutes. So we'll come back to that point. Keep it in mind. Does the US have any socialized medicine? Well, obviously we do. If you're getting Medicare, as I do, it is a government-sponsored program. Yes, we pay taxes for it, but so do Canadians pay for their health care as well through taxes. Medicare is a form of socialized medicine. Everyone over 65 is entitled to Medicare. It is a benefit. Yes, we pay taxes, but it is also partly paid for out of general taxes, not just the taxes that you may have paid for individually. Medicaid is socialized medicine for the poor who have access to Medicaid, mainly in northern states and southern states. Medicaid can be a little dicey. I'll come back to that point a little bit later. Veterans get free health care. Members of the armed forces get free health care. Native Americans, through the Bureau of Indian Affairs, often have access to free health care. And your local congressman is getting a healthcare system supported by your tax dollars. So there is socialized medicine in America. And in fact, it's a significant part of our healthcare system that we often don't like to talk about. Well, all right, let's get to the meat. How do we evaluate the systems? I've talked about the variables. Let's see what, in fact, we can learn from looking at them. Well, one thing you might want to evaluate is public support. I'm not going to give you too many public opinion polls. I'm just going to tell you that public support for the American healthcare system is the lowest among the G8 countries. The United States has the least support for the healthcare system. Most Americans do not like the healthcare system. Interestingly, however, they like their doctor and they are supportive of their doctor and often think that their hospital does a good job as well. So there's an interesting paradox here. Americans like their doctor. They often like their local hospital, but they have a very negative view of the healthcare system in general. Contrary to what goes on in Europe, where most Europeans and Canadians hold the healthcare system in very high regard. You may recall the Olympics when they were held in London, that the NHS was the at the opening ceremony was the major thing that was highlighted by the British. They really went all out with nurses flying around and all kinds of wonderful things happening at the London Olympics. So let's compare systems on cost, access, and quality. We want to know whether or not the United States healthcare system is costly, whether it's accessible, and whether it's of high quality. To determine the issue of quality, I'm going to look at healthcare outcomes. Things like cancer survival rates, infant mortality rates, and maternal mortality rates, readmission rates to hospitals, immunization rates, and the gold standard, avoidable mortality, which I'll explain in a few minutes. All right, let's look at cost. The United States spends about 17% of its gross domestic product on healthcare in 2018. So this is a pre-pandemic number. Who the heck knows what it's going to look like in 2020? But in 2018, 17% of our GDP went to healthcare. Compare that to France, which the World Health Organization ranks as the best healthcare system in the world, at 11.2%. Germany, about the same, 11.2%. Canada, 10.7%. And the United Kingdom, which is among the also highly rated healthcare systems, along with Germany, at 9.8%. So we are spending way more for healthcare and getting, as you'll see in a minute, outcomes that are not as good. If you look at it slightly differently, how much does each individual spend on healthcare? What is the per capita spending on healthcare in the United States? In the United States, about almost $11,000 is spent on healthcare per capita. In Germany, that number is almost half, 66646. In Canada, it's 5,400. In France, 5,300 roughly, and in the UK, around 4,600. So you can see the United States on a per capita basis is again spending almost double what other countries are spending on healthcare. This is data that I get from the Commonwealth Fund, which is probably the most prestigious source other than the OECD for data on healthcare. Another cost issue is what we call the overhead cost, the administration cost associated with running our healthcare system. Woolhander and others have estimated that about 1 in 4 American healthcare dollars goes for overhead, meaning administration costs. In other countries, that figure is usually around 8%, sometimes as high as 12%, and that's it. So we are spending twice as much on overhead, if you will, than other countries. And what we might think about it is that this is non-health dollars. This is going for people to, code a particular visit to a doctor, code a visit to a hospital, trying to seek reimbursement from multiple payers have multiple forms and multiple reimbursement rates and things like that. The way we've organized healthcare system has produced high administrative costs, which is why Bernie Sanders was arguing for a single payer system, because if you go to, for example, a Canadian hospital, you're not going to run into too many bureaucrats along the way because Ontario is the health insurance company. And you send the bill to Ontario and they send you the money, hopefully. All right. So that's the cost issue. Let's look at access. 10.7% of all Americans under 65 do not have insurance. 29 million, even after Obamacare, folks, this is post-Obamacare, still don't have insurance in 2019. Why? Because Medicaid expansion was refused by the southern states and some of the western states, so in Texas and other states where there are millions of people that are uninsured, Medicaid expansion was not allowed. And so consequently, there are millions of people who would be eligible for Medicaid if they lived in New York or Massachusetts, but because they live in Texas or Arkansas, they cannot get it. Interestingly enough, even of the uninsured, about 50% of them would be eligible for Obamacare, but they do not know that they are eligible because outreach during the Trump administration completely stopped. There's no advertising, there's no outreach, there's nobody signing up. And so consequently, the effort to recruit people for what might in fact be available to them has really led to a great number of people being uninsured unnecessarily. Minorities obviously are more likely to be uninsured than white Americans, and you can see the data there with whites almost 60% less likely to, more likely to be insured than Hispanics. So Hispanics have the highest rate of uninsurance of any group, 11% for blacks, and again, 8% for whites. What I want to really emphasize is that it's not just a problem in America of lack of insurance. At least 43%, this is a stunning number to me, 43% of adults between the ages of 19 and 64 are underinsured, meaning that a greater than 10% of their income is being spent on out-of-pocket costs for healthcare. That's a lot, more than is typically recommended. It shouldn't be any more than 6 or 7%. So what we have is that a very significant number of Americans do have insurance, and they think that insurance is adequate until they actually get sick and they find that it's inadequate. Just a couple myths. Most people who are actually uninsured actually are workers, people who already have a job, and consequently, there's a myth here that it's the lazy or et cetera, but 73% of all people who are uninsured live in a family where at least one person is working, and so they are the spouses or the children of somebody who is working. So there you have it. And many of the elderly, even though they're covered by Medicare, are underinsured as well. They have no Medigap or Medicaid. So 10% of the elderly who have Medicare, again, are underinsured because they cannot afford Medigap and they are not eligible for Medicaid. So how do we compare on quality? We've talked about access. On quality, the World Health Organization ranked us 37th in the early 2000s. Not much has changed to change our rank. The United States ranks lower on maternal mortality, life expectancy, and infant mortality than most of the G8 in European countries. And as one Dr. Bodenheimer, who has written the text that I always use when I teach about healthcare policy, has argued that in the United States, the problem is we have too much care for some, like people like me and probably people like you, and too little care for many. Many of us get not only high quality care, but to some extent, we get more care than we actually should be getting, not because we're stealing it, if you will, from somebody else, but we're getting too much care because it's not good for us. Too much testing, too many operations. We don't need it. All right, let's look at some of this data just to prove to you that what I say is true. This is, again, data you can all look up from the Kaiser Family Foundation or Commonwealth or go to OECD. Japan's life expectancy at birth, this is both sexes together, 85. So it's good to be Japanese. Australia, 83. South Korea, 83 and a half. France, 83. Canada, and as you can see, the United States lags behind. So basically, you're going to have 2 or 3 more years of life, maybe up to 4 years more of life, if you can get to France, South Korea, Australia, or Japan. Actually, that's not true because those people have different styles of life. You don't automatically get more life if you move to Germany. So I didn't mean it that way. What does life expectancy data tell us? Well, I don't want to make more of this than there really is. Life expectancy data is really a crude measure of quality because we all know there are other variables that affect our life expectancy, including how much inequality there is in the United States. So compared to other countries that we are talking about, particularly here, the G8, the United States has much more inequality, much more poverty than Canada or the United Kingdom or France or Germany, et cetera, or Australia or New Zealand or any of these countries. And so consequently, the amount of inequality we have is impacting our life expectancy. So I would agree that life expectancy isn't the best measure. But interestingly enough, if you look at life expectancy after 65, not at birth, but after 65, when everybody who's over 65 in America is covered by Medicare, i.e., everybody has at least some health insurance, it turns out the United States becomes more competitive. We still lag behind, but interestingly enough, after 65, the gap closes, and so we do better. So obviously, giving everybody healthcare insurance does have an impact on life expectancy. More key comparisons: breast cancer, which is a popular thing to look at. People often talk about, well, the United States does such a good job with cancer. We do. There's no arguing that. Breast cancer, for example, 5-year survival data does indicate the United States does very well. But so do other countries. It's not like as if other countries don't do well. Sweden, which has national health insurance, Canada, which has national health insurance, Germany, which has national health insurance, all do comparably well. It's almost identical. In the case of Sweden, in Germany lags a little bit behind, not much. The outlier here is the United Kingdom, which has historically seemed to have a little bit of a problem on the breast cancer front. We're not exactly sure. The English have been spending a lot of time investigating that discrepancy, and it probably has to do with mammograms and testing for breast cancer in the United Kingdom. Cost as a barrier to access. It turns out that in the United States, almost 1 in 3 Americans say that cost is a barrier to accessing the healthcare system. In other words, that they simply skip care, don't go to a doctor, or don't go to a hospital, or don't go to an emergency room because of the cost that they anticipate with accessing care. Those figures are much lower in other countries. In Germany, only 7% of Germans, 7% of the Brits, 8% of the Dutch will argue that cost is a barrier to accessing to care, while in the United States, it's 1 in 3. Again, inequality. If you look at the inequality gap in access by nation, there's 2 points here, for example. This is lower income, this is higher income. What's interesting, if you skip down to the US, 50%, again, of lower income Americans will respond that they skipped getting care or getting drugs, filling a drug or filling a prescription, because of the cost. Interestingly enough, bizarre as it may seem, as much as 27% of Americans of higher income also said the same thing. If you look at that figure, for example, for the United Kingdom, only 12% of people who are in lower income report skipping care or skipping accessing a prescription. And among the higher income people, only 7%. So the data, again, seems to suggest a significant discrepancy. All right. MRIs per million in the United States, well, we've got plenty of them, as you can see. United States has 38 MRIs per million citizens. Germany does almost as well. But other countries that we compare ourselves to, remember I talked about rationing by supply? Other countries have decided to ration access to some high tech on the argument that there's too much testing, that if you do not need that many MRIs, you do not need that many CAT scanners, and that there's no evidence that having more CAT scanners and MRIs increases healthcare outcomes or improves healthcare chances. And the data seems to support those countries because their life expectancy is higher. Well, the counter argument that many people anecdotally will say, well, but in those countries, you can't get an appointment because they have um, rationed. Well, ability to get same day appointment when sick. Actually, the Brits don't do all that well. They could do better. 57% argue that they can get a same day appointment, which is actually is a pretty high number. But in the Netherlands, it's 77%. In France, 56%. In the US, 51%. So the United States doesn't do much uh, uh, worse than these other countries, but the other countries also do well. And the point I'm trying to make with this slide is if you have a national health insurance system, you can get the same day appointment when you're sick. In fact, most countries actually do better than the United States on same day appointment. Canada, however, does not do as well. And that's a complicated story, which I'll save for another day. Wait 2 months to see a specialist. Well, in the United States, actually, we do very well. There's very little waiting for those of us who have health insurance. Only 6% of Americans respond that they had to wait more than 2 months to see a specialist. In Canada, that figure is a little high. In the UK, it's a little high. But in France and in Germany, it's actually even lower than the United States. So the point I'm trying to make with this slide is some countries with national health insurance do a good job of having access to care and access to specialists and same day appointments, and some don't do as well. So it's not the national health insurance, but it's the organization of their systems that really impact whether or not they can do well or not. Now I'm going to spend a few seconds here on this one. I'm trying to finish this up, I know, before 4 o'clock. But this is the gold standard. This is the gold standard slide that most healthcare experts would point to. What percent, how many deaths occur per 100,000 that we could say are avoidable, that we would argue that access to care, early intervention, screening, testing, or early intervention with drugs would have made a difference and avoided death. Well, in America, it seems that about 112 deaths per 100,000 are avoidable. That is to say, early intervention, access to care would have prevented death. In the United Kingdom, they find that that number is about 85 per 100,000. In Germany, 83, Canada, 78. France, which is why they're number one, is only 61, meaning that the United States doubles, if you will, almost the amount of avoidable deaths in our country. So we do much worse than France in making sure that people who would have benefited from healthcare and prevented death actually had access to it. So, if we're going to change systems, what would it look like? If you've been convinced that maybe the United States can do better, what would it look like? Should we have a system like Germany or a system like United Kingdom or a system like Canada? Well, one of the reasons I want to spend just a couple minutes as we finish up this webinar is for you to understand that, and this is one of the problems I have with the Democrats' discussion of healthcare. Bernie Sanders has really taken over the way Democrats think about healthcare. For them, and for many Democrats, it's the Canadian model and single payer systems or nothing. In other words, they've looked at the Canadian model, the single payer model, as the only way to organize a healthcare system, contrary to in opposition to the United States. Well, in fact, if you look at the United Kingdom, if you look at Germany as two examples, they are very different than Canada. Americans often don't understand that. Healthcare systems can differ on a whole host of variables. For example, they can be centralized, like they are in England, or decentralized, like they are in Canada. They can provide first dollar coverage, meaning that when you go to a doctor, it's free. When you go to a hospital, it's for free. Or there could be co-payments and some out-of-pocket costs, like there are in the Netherlands, like there is in Germany, etc. So some countries do ask people to continue to pay, but it's very modest and not a burden. How do we pay doctors can differ. Should it be fee for service, capitation, or salary? Different countries come to different solutions for that. Should there be competition? For example, in the United Kingdom, it might come as a surprise to some of you out there that in the United Kingdom, there is the British National Health Service, which about 80% of the British access, but there is also a private system. So if you don't want to get service from the British National Health Service, you're perfectly entitled to pay for private health insurance and access a private health care system. Most Brits do not. They do use, some middle class and upper middle class people do use the private system as a way of getting around the queue or wait times for knee surgery or hip surgery. But most Brits will tell you that if they have a serious disease or a serious illness, they're going to use the British National Health Service, which is the most prestigious provider of care in the United Kingdom. So you can have private care or not. For example, in Canada, there is no private care. It's prohibited by law, by Canadian law. But in the United Kingdom, there is private care. In the Netherlands, there is private care. In Germany, there is private care. So it's not all the same, but Bernie Sanders makes you think it is. So to sort of wind this up, I'm just going to talk about these three different systems. In the United Kingdom, again, we talk about the beverage model, which means that this is a healthcare system, which is in fact a national health system funded by taxpayer dollars. The hospitals are indeed owned by the government, and the system is highly centralized. They have been making efforts to decentralize the system. They have been trying to build in competition into the UK system. But my point is that the British National Health System is indeed a centralized system, a national health system, and people can access the private system if they wish. That's to be different from, let me just jump to the third bullet, the Canadian model, which is a single payer system, but it's national health insurance, not a national health system. What does that mean? It means in Canada, everybody has Ontario insurance, British Columbia insurance, depending on what province you live. That province is your insurance company. The hospitals, however, are not owned by the government. They are private, not-for-profit entities. Do the doctors work for the government? No, they do not. They bill the government just like they might bill Prudential, Aetna, or United here in the United States, but they often work on fee-for-service. Some might work on salary. Some may work on other more hybrid systems. But in Canada, the doctors are private. The hospitals are private. The system is not owned by the government. Just individual insurance is provided by the government. That's different than in Germany, which looks more like the United States in the sense that it's an employer-based system. People get their health care from their employer. Their insurance company is a private, usually not-for-profit insurance company, much like the United States looked during the 1950s and 60s when we used to access Blue Cross and Blue Shield. And then there are hybrid systems like the Netherlands and France, et cetera, et cetera. And then there's the United States, which is a non-system. We have some socialism here in America with Medicare and Medicaid, et cetera. Our states are different in how they provide care, and there is no real organization to our healthcare system. It's kind of a competitive capitalist model for organizing healthcare. And so I really wanted to hammer home these distinctions for you to understand that national health insurance and national health systems differ in different countries. They are not all what Bernie Sanders has been talking about. I would argue, and I'm just going to wind this up because I want to give people an opportunity to ask questions. I would argue that if I were, and I'm not anytime likely going to be asked, but if I were asked which model is better for the United States, I would say the German and the Netherlands model looks more promising as a model for the United States than Canada or the United Kingdom. Why? Americans are not comfortable, I think, with the government providing the insurance. I think they would be more comfortable going back to, if you will, a Blue Cross Blue Shield private nonprofit insurance model that would be easier to swallow, something more consistent with our history. And so they would still have choice of insurance. They would still have choice of doctor, still have choice of hospital. The system would seem very familiar to us, and we would get improved outcome. The difference between the United States today and Germany, Netherlands, and other countries that have what I call the Bismarck model is this. They have a big safety net. In Germany, if you lose your job, the German government becomes the insurer of last resort. So it will continue to pay your insurance premium and make sure that everybody has access to health insurance. So the difference between Europe and the United States is nobody is allowed to fall through the cracks. Everybody is guaranteed insurance. But the difference is in Germany and the Netherlands, for example, everyone is allowed to choose their own insurance, shop around for insurance if they choose, or just simply rely on what their employer or their union may provide as their insurance. In Canada, which has a national health insurance system, the only way you can change insurance companies is to move from one province to another. And most of the provinces' insurance look pretty much alike. I don't think Americans are ready for the United Kingdom model, though the United Kingdom model is excellent. For the most part, the United Kingdom model would mean that we would have to accept a government-run system, not only where our insurance is provided by the government, but our hospitals are owned by the government. And I don't think, even though it works in the United Kingdom has an excellent, excellent healthcare system. Their outcomes are better than the United States almost across the board. But I don't think Americans are ready for that change. So, interestingly enough, as a political scientist, I would say Bernie made a mistake. We are looking at the wrong country as our model. I have a little bit more I could say, but I'm going to end it here because we are at 4 o'clock. And I think we ought to give people an opportunity to ask questions if they wish to. So that is the last thing I'm going to say. And thank you so much for your patience. I know this was a lot, and I'm happy to take emails if people want to send it to me, and I can give you detailed information at a later time. Okay.
All right. Dr. Weiner, thank you so much for that marvelous presentation. And you do have some questions waiting in the wings there.
Okay.
So let's get right to those. Before any of you leave, let me just say that Dr. Weiner's talk has been recorded and will be available at the CCT website sometime in the next couple of days, but don't hold me to that. I mean, it will get up there when it gets up there. So Sephora has said that it could be available as soon as a day and maybe in the next several days. So please feel free to access that recording. So let's go to a couple of these questions here. We have quite a number. And let's start with Seymour, who's asked, Seymour Birchman, who's asked several questions. He says, how many cases in the UK and Italy were due to the first wave versus later wave, I assume, of coronavirus? They had much less time to prepare for the first wave. Dr.
How many new cases?
How many cases in?
Well, let's see. I have the Italian data. It's about 146 cases per 100,000 right now, is the number. And the what's interesting is what I call the case fatality rate, which is how many people who get the disease are dying of it. And interestingly enough, Italy is the worst. They have a 3.5% case fatality rate, and that number is getting, it's stable, but it's kind of going up. because of the new variants. But for the most part, Italy has the worst case fatality rate. Just to give you some example of that, United States, and here's an example where the United States does well, right? We've done terrible in preventing the disease. Many, many more Americans have COVID than should have it. Many more Americans have probably died of it because more Americans got the disease. But one of the good things that we can look at is the case fatality rate. In the United States, only 1.7% of Americans who got the disease died, while in Italy, it's almost twice as much. And so we've done, because our doctors and our nurses and our hospitals finally got their act together and finally got the PPE and all the equipment. It took a long time, but we've been able to, due to the success of our also pharmaceutical industry, Regeneron, and all this other stuff, we've done a pretty good job of dealing with people once they get the disease. Italy has not done that as well. And I must say that one of the reasons for that is Italy doesn't have, of the G8 nations, Italy is among the weaker of the healthcare systems. They do not have a strong healthcare system, much like Spain. Their data isn't good.
Okay. One other question from Seymour. He has several more. I might jump on to somebody else after the second. Seymour asks, should we consider relative emphasis and prevention and wellness versus a sick care system, which is what we have in this country now? He says, my understanding is that we have a very costly system and with much poorer health outcomes. Is that true?
I love that question. That's like, I teach a whole course on that. That's exactly right. And that is the main point of my webinar, really, which is, again, remember I mentioned that we ration on price. Most European countries ration on supply. So they have fewer MRIs and CAT scans in high-tech investments. Why? Because they've invested in two things. One is they've reduced the inequality in their societies, which I would argue is the single best thing you can do to improve the healthcare of a population. All the data from any public health expert in the world would tell you, if you want to improve life expectancy, maternal mortality, infant mortality, and other kinds of important healthcare outcomes, getting people good nutrition, good food, adequate housing is the best investment. Having said all that, what we also learn from looking at the data is that investments in public health pay off way better than investments, frankly, in high-tech equipment. So yes, you can get a new MRI, but are you better off making sure you've got that last baby vaccinated, right? In other words, getting your vaccination rates up, getting your, bringing down obesity rates, working on drug and other kinds of problems like drug addiction and opioid addiction and things like that. So investments in diet, nutrition, public health, vaccination, and other kinds of outreach, which is what other countries do a better job than the United States does. The United States has a weak public health outreach. We don't do a good job. You still can be a baby in America. We have some data that maybe 1 in 10 or more children go to sleep at night in the United States hungry. That's not going to make for good health.
Okay.
So bingo for that question. Best question.
I'm glad that was we don't have a bingo award for that.
Yeah.
At least
yes.
Question. We have a question here for Pete Stiles has a number of comments and questions.
Sure.
He says Obamacare was one of the worst AWS, I guess, ever passed. I'm not sure what that is, Pete. Maybe another time you can tell us. 33,000 pages of legal obscurity, etc. And he says 75%. Just to kind of summarize this, of the ACA co-ops failed immediately. result, good doctors will not take Medicare without supplemental coverage and absolutely will not take Medicare patients. Therefore, indigent and up, back, and up. Oh, indigent and up, back to the emergency rooms. Oh, back up. I get it. Okay. What do you think about that?
Well, I have several comments. One is that I'm often, when people criticize Obamacare, I'm often thought, I'm brought back to Winston Churchill used to say about democracy, which is the worst form of government except for all the others. Um, Obamacare was not the best solution to our healthcare problem, but it was better than anything else that was out there at the time. Certainly, the Republican alternatives were terrible. And so, what Obama did was pass an imperfect law that improved conditions fairly dramatically for a lot of people. But I will concede that if I were a healthcare provider, I would be only moderately excited because it did increase paperwork, and to some extent, some healthcare measures were implemented that, on second thought, probably should have been rethought. Um, Nonetheless, the data on Obamacare's improvement of healthcare access is indisputable. Uh, 20 million people have health insurance today that wouldn't have had it before. And the number would have been 30 or 35 million had the southern states been forced by the Supreme Court to accept Medicaid expansion, which the Supreme Court, in its wisdom, chose not to require. They struck that part of the law down. Is the law need reform? Absolutely. So I will agree with those physicians who say that there were many parts of the law that need some reform, need some second thinking, and I agree. So there's legitimate criticism of Obamacare, but at the time, in 2010, it was the best the government could do under the circumstances. The only alternative was the status quo, and I would argue that if you go back to the 2010 data, no reasonable person could argue that the status quo was acceptable. You cannot have 50 million Americans without insurance. That's not unacceptable. And when that burden falls so heavily on minorities, it's not right. Because if you were Black, if you were Hispanic, think about the veil of ignorance. How would you feel if you were them?
That's a good principle. I like that one. Veil of ignorance. The veil of, what did you say again? That was, Terry, the
Veil
veil.
of ignorance. It's John Rawls's concept.
Yeah,
Happy
John
to
Paul's
talk more about that at some point.
very powerful principle. Pete does try to make one more point here. It's an interesting one. He talks about the backlog of patients lining up for care in places like the UK and Canada, which we don't seem to have here in this country. So the waiting period here is, as you pointed out already, much greater. Any additional comment on that?
Well, yeah, I think that people don't appreciate that the waiting data is usually on elective surgery. So, yes, if you're insured in the United States, you're going to wait less. You're going to wait. The data showed that the United States does very well in getting people to the surgical suite compared to other countries. But some other countries like France and Germany do just as well. So it's not just, well, if you have national health insurance, you're going to screw everything up, right? Yeah. That's not true. But in the United Kingdom and Canada, you do wait a little longer. But I must tell you that in Canada and the United Kingdom, if you look at emergency care, they do just as well as the United States. So what they're doing in Canada and what they're doing in the United Kingdom, but they're not doing in Germany or in France, is they're making people wait a little longer to get their knee and hip replacements. That's true. There's no denying that they've made that choice. But remember, you'll wait a long time here in the United States if you don't have insurance. You'll never get it.
That's a very good point.
You're never going to get it.
Thank you.
So that's a long wait.
Real good point. Thank you, Terry. Let's move on to Joan Carter. She says, I think there's no hope for change here while we still blame people for their own poverty. It sounds like a philosophical comment, doesn't it?
Yes. Well, that's a whole different CCT seminar, but let me just say this. There's no question there are individuals in our society, both who are poor and disadvantaged, who have made a mess of their lives and made poor choices. But the vast majority of the disadvantaged work, they have jobs, they do not commit crime. We just had a webinar that the MCA had, for those who are dually, went to the MCA, that, for example, that 90 to 95% of people who are poor or disadvantaged do not commit crimes. They're not, breaking windows. They're not stealing. They're doing what they're supposed to do. They just don't make enough money. And their employers, not always because they're miserly, their employers aren't offering insurance not because they don't want to, they can't afford it, right? So it isn't making any sense. In Germany and France, employers are required to offer insurance. Well, that creates a level playing field, right? In the United States, if I offer insurance and the pizza place down the block doesn't offer insurance, I'm going to have to sell my pizza for more than they are, right? But if they all have to offer the insurance, that pizza is going to be the same price, and I'm not at a competitive disadvantage. So what in Germany and in the Netherlands have done is, if employers are required to offer the insurance, everybody's on a level playing field. And the cost of your products may go up, but it'll go up for everybody. So, and if for some reason the business can't do it, then the government will step in and be the insurer of last resort. We can figure this out. And the cost is not prohibitive because those countries, Germany spends 30 to 40% less than we do on healthcare and gets better healthcare outcomes. So it's not cost.
And how do you account for that, Dr. Weiner? How do you account for the fact that we spend significantly more and don't get a better
Well, it's complicated, but I think the most of it is, well, one is administration cost, the high, if you're a provider here, you've got multiple providers, multiple codes, and, half your energy is spent, taking seminars on how to upcode to get more money from Medicare than you might be entitled to. So the result is you have a gaming of the system, a lot of effort in America to game the system, high administrative costs, high investment in technology to get a competitive advantage by hospitals and doctors. And it's just irrational. Why did the Germans get away with less? Because they have a much more efficient system, right? German engineering at work. They make sure that the reimbursement rates are regulated so that all insurance companies are pretty much offering the same reimbursement rate. You don't get a different reimbursement rate for a procedure depending on what insurance company you're billing. So there's no reason to discriminate against patients based on their insurance. There's just a great deal of rationality organized in Europe, particularly in Germany, the Netherlands, and those countries. I've been to those, particularly the Netherlands. I've spent a long time there, a lot of time talking to doctors and hospitals. And to tell you the truth, the Netherlands system, it looks like Obamacare. It's really, the principles of it are Obamacare, just that nobody's allowed to fall through the cracks. Nobody's on Medicaid, if you will. They don't have Medicaid, but everybody gets employer-based care. And if they can't afford it, then the Netherlands provides it for you. They give you a subsidy or literally give you a voucher, and you go out and buy insurance on the marketplace yourself. And the result is everybody is cared for. Let me just say this about saving money. What Americans don't understand is if you have a lot of people who are uninsured, it's pay me now or pay me later, right? If people are uninsured, if they are not taking care of their health, they're going to show up on your doorstep anyway. They're going to come to your emergency room and you're going to have to cut their legs off because their diabetes wasn't taken care of. So now instead of giving them a nice drug from Merck that might take care of their diabetes at an affordable price, now you're doing operations. Now you're engaging in rehabilitation programs. Now you've got to get this person, a home care person, because they, you have to wheel around. They can't, they're no longer mobile. They've lost their job. We don't understand that if everybody is insured, it's cheaper. It's cheaper because you don't have all these other expenses. You keep people healthy and you're going to bring down costs. Other countries seem to have learned this, but we have a hard time in the United States getting our head around this.
That's interesting. Thanks for that little added note there, Terry. We have a kind of is it too late question from Harvey Oriel. Harvey says, is it too late for the US to become a single payer system like our neighbor in Canada?
I would say yes, and I don't think we should anyway. That's the point. One of the things that's why I emphasized the German, Netherlands, and the UK model, that there are other choices, and the Democratic Party has made a mistake by continually turning to Canada as a model for the United States. Mm-hmm. It's not going to happen. Okay, I'm going to, it's not going to happen. Just like the Mets aren't going to win the pennant next year, it's not going to happen. There's no way the American people are going to turn a system which has some degree of tiering in it, meaning that some people are able to buy better insurance with more amenities than others, and cash in our system, which 60 to 70% of Americans enjoy wonderful care and wonderful benefits, leaving another 30% to enjoy not very good care. But my point is, they're not going to politically do it. They're not going to do it. They might be persuaded, I think, to accept a German model, which is employer-based. We're all familiar with it. Right? We're all familiar with that. We get our insurance through our employer or our union. Okay. The idea that everybody should be insured if they lose their job, I think Americans could live with that. We could get behind that. Not everybody, but a lot of people could get behind that. That we ought to have some reasonable rationality and decision making about high technology investments versus public health. I think we can get people behind that, right? If they're shown that some of the data is that we do too much surgery, too much testing, it doesn't improve healthcare, right? For example, if you look at Germany and you look at the United Kingdom and you look at deaths, cardiac deaths, they do 1/3 less cabbage surgery than we do, but they do not have poor outcomes, right? They get people on medication earlier. They show them the way to the gym. Here's your Vent Fitness card, or your, go to Crunch or LA Fitness. They get people to look at alternatives before they are going to engage in surgery. Other countries also have lower C-section rates, for example. So there is ways to save money by upfront cost. In other words, investing in public health, investing in prenatal mortality, getting women to see the doctor earlier, making sure that they have a doctor early on. They don't show up with the baby at 8 or 9 months. That these kinds of investments can prevent C-sections and all kinds of things, and low birth weight babies and what have you. So it's about putting some rationality into our system, and money can be saved. We're wasting it. It's really heartbreaking. To tell you the truth.
It is. It is. And
yeah.
We have a comment from Herbert Townsend. He says, why not make Medicare an option for everyone? Remember that? And
well, I think that's a first step. I mean, if I were if you're trying to Band-Aid, remember we talked about the way that suggestion probably is what's going to happen. We're slowly but surely going to Band-Aid our way to a system that makes a
Really?
little bit more sense. One way of dealing with our system is to give people 55 and over an opportunity to buy into Medicare. I think that makes sense. Many women are discriminated against by Medicare if they're married an older man and he dies, and with him he takes his own insurance. Very often, women find they are widowed or divorced and find themselves without access to health insurance. They should have access to Medicare or Medicaid. So there is ways we could Band-Aid our system, but it's not going to save us very much. The problem with the Band-Aid model is you keep putting Band-Aids on, but you increase cost. We're not doing anything to rationalize our system to bring the cost down. You cannot spend 100% of your GDP on healthcare. Okay, we need to understand there are other needs in our society. We want to go to Mars. We want to have our schools. We want to have highways. We want to have other things that we want to spend money on, and we have to defend ourselves from some kooky countries out there. So we have to invest in defense. We have other things we need to spend money on. It can't all go to health. And the more it goes to health, the less money there is for schools, children, other investments as well. And so I would argue that countries that can get away with the health outcomes that we're looking at, with 10 or 11 or 12% of their GDP being spent on healthcare, somebody ought to say, maybe they're doing something right. And we don't have to buy the whole thing, right? Just because you look at a model, you don't have to say, well, we're just going to buy Germany. We're going to take the German model. We could take some things and we could leave other things. We can go shopping, take some things from Germany, take some things from the Netherlands, take some things from the United Kingdom, and build a system that works for the United States, but that guarantees everybody has health care. That is the fundamental principle. Everybody should have it, and it should be accessible, it should be affordable, and it should be of high quality.
Excellent. We have a little bit of time left. We have a question from Bill Pope.
Bill.
Yes, part of the CCT board and former president, not of the United States, but of the CCT. And by the way, I don't know if you're asking CCT to endorse your suggestion that women only do not marry older men. Was that part of your suggestion?
Well, if women were smart, they'd marry younger men.
We'll leave it at that. Okay. For fear we get censored by somebody.
Right. I'm going to start down this road.
How can someone argue against having a government option? Retain private insurance and allow people to have a choice. That doesn't eliminate the private aspect.
Well, I agree with that. That's what I call the Band-Aid approach. I absolutely agree that the two most likely solutions that Biden will pursue, remember the path dependence model, once you're stuck with the system, it's hard to get people to change.
Yes.
And so we probably will do it, just like Winston Churchill said about America. We're just probably going to do the least efficient thing, which is to Band-Aid our system by probably opening Medicare up to 55-year-olds or creating a government option for those people who do not have access to private insurance that's affordable. But that doesn't solve the Medicaid problem. That doesn't solve the problem of the poor. And it doesn't deal with the enormous costs in our system, the high administrative costs. So it's a solution that will probably be chosen by the Democratic majority in this next 2 years. I think it's better than nothing. I support it, but it isn't what we ought to be doing.
Okay. In that case, Ted Olson asks, if you were president, what would you do of the United States, we're assuming, out of CCT? What would you do to reduce costs? That's a tough question.
That's a tough question. I think the first thing I would do is to try to rationalize how we pay doctors and hospitals, to take the um, models that we get from Germany and other places to make sure that all doctors have one form, one system of reimbursement, one reimbursement schedule that makes sense. Medicare has already done that with the DRGs to some extent, but the billing system needs significant work. That's where, you know, as one famous economist said, follow the money. Uh, you need to look at how hospitals are paid, how they are reimbursed,
Yeah.
how doctors are reimbursed, and to create a system that is fair to doctors, fair to hospitals, and fair to the public.
Yeah, I think follow the money is always a good solution on the economic front. I think we're pretty much out of time. I just wanted to mention that Ted Race, Ted Rea says you have not mentioned malpractice, but I don't think we have time this afternoon to go into that. But malpractice certainly an
Well,
issue.
most European countries have rationalized malpractice.
Uh,
Certainly in the United Kingdom, most doctors have their malpractice paid for by their hospitals or by the community care groups that they belong to, clinical care groups. The uh, culture of malpractice is under control. There's in Sweden, for example, there's no fault malpractice. You know, one of the reasons people sue for malpractice in America is there isn't a sufficient welfare system to take care of people with cerebral palsy. In other words, if you have, let's say a baby is born with cerebral palsy. Well, if you don't have, if you're in a state that has poor care, like Texas or Arkansas, you sue your obstetrician so that you can have money to take care of your kid. There may have been malpractice. Most likely, there probably wasn't malpractice, but people sue to really buttress the fact that we have a very poor welfare system to deal with disability in the United States. People who are disabled don't have adequate resources. Having said all that, I completely agree with the physicians. Malpractice is out of control. There needs to be significant malpractice reform. Doctors do practice probably some degree of defensive medicine, which raises costs, and it's crazy. It's just crazy.
well, what else can we say except
Yeah.
thank you, Dr. Terry Weiner. You all know about the recording will be available, and I have to thank Terry for this marvelous presentation. Thanks to Sephora for her technical help, um, and to the audience for tuning in today and staying around to the last minute. My
There you
goodness,
go. Yeah. Thank
folks
you.
there. That's a testament to how good this presentation is. There are a lot of people out there suffering, no question. And so the medical issues in America are significant ones, and they have driven several campaigns here recently. So thank you for addressing those. And I thank you all for being here today. And this is Thursday, and the weekend is coming. So I hope you have a good weekend. Thank you
Okay.
all, and we'll see you another time.
Thank you. Bye bye.